community health outreach nurse educator and faculty right now at Concordia University doing population health. I am, I think, the only nurse on the team right now, so thank you for having me. Here. Thanks for being here. And I'm on the value-based subcommittee as well.
Larry Lyon, I'm a family doctor. I'm at the Oregon Medical Group in Eugene. I'm also on the Trillium Clinical Advisory Panel. And I think and I'm on the evidence-based sub.
Good morning, Dawn Moutner, she, her, and they are my pronouns. I serve as the Medicaid Medical Director for the Oregon Health Authority, which means for the fee-for-service or open card program, and then also as liaison for the CCO Medical Directors.
Hi, I'm Valerie King. I am one of those card-carrying physicians, but also an epidemiologist, and I at the Center for Evidence-Based Policy, where I'm a research director. And do you want to pop in there?
The pronouns. I'm the Director of Delivery System Innovation at OHA, and the HERC sits within us.
Great. I am Holly Jo Hodges. I'm a family medicine OB physician, clinical practice for 19 years, most of which was done in Prineville. And I now am the chair of the BBBS and also the CMO of Eastern Oregon CCO through Moda Health.
I'm Linnea Lindsay. I'm a clinical psychologist. I am on the HERC and I'm the chair of the Evidence-Based Guidelines Subcommittee. And I'm also a deputy director of behavioral health for the state of Oregon.
Yep.
Just those things. Travel. I'm on HERC and BBS, she, her pronouns. I'm an orthopedic surgeon professor at OHU.
Thank you, everybody. And online, we have a couple of people who are members or staff. I'd like to give them a chance to introduce themselves specifically. Well, I know Mike is driving, so I'll speak for him. So you have to. Oh, maybe you can speak. Go ahead, Mike, if you're able.
Good morning, everyone. Mike Collins, Confederated Tribes of Warm Springs, Director of Managed Care.
Great. And Mike planned to be here on time, but there was a traffic incident that he's navigating around. So thank you, Mike, for listening in. And Antoinette.
Hello, good morning. My name is Antoinette Iwachi, and I am the Senior Public and Regulatory Affairs Specialist for Cambia Health, also known as Regents Blue Cross Blue Shield of Oregon. I have more of a legal JD background, but no medical background, and I'm part of the VBBS subcommittee. Thank you.
And last but not least, live from Ohio, Dr. Heidi Gullett, who joined our team April 1st. Go ahead, Heidi.
Thank you so much, Jason. It's a pleasure to be with you all. I'm a family and public health preventive medicine physician and looking forward to working with you and for a wonderful day today. Thanks.
So Heidi has joined us. She'll be parallel to Ariel's role. So really looking forward to having another clinical eye on the meeting materials and another perspective as we bring you evidence and information to help guide you in your decisions. And with that, I'll turn it over to Claire to give some updates about what's going on in the agency and the broader world. So take it away, Claire.
Thank you again for having me today. And it's to meet you all and to have broken the ice a little bit. As I mentioned, I'm Claire Pierce-Vogel. I started as the Director of Health Policy and Analytics in November of this past year. And the prior role before coming to Oregon, I was working in the White House Domestic Policy Council as the Healthcare Delivery System Reform Director. I oversaw the implementation of the Medicare Drug Price Negotiation Program and the drug pricing provisions related to under the Inflation Reduction Act, which were referred to as a commendable goal in the president's executive order this week. So I'm taking that as a win. The other work I led there included overseeing Medicare Advantage and Part D policies and policies at the CMS Innovation Center. I also spent time in the past administration and in administrations prior at the U.S. Department of Health and Human Services. So most recently was the counselor to the secretary, where I was the senior policy advisor over the Agency for Healthcare Research and Quality, the National Institutes of Health, helping to launch the ARPA-H, the Advanced Research Projects Agency for Health, as well as the CMS Innovation Center and Office for Health IT, which transitioned to the Assistant Secretary for Technology Policy while I was there. So I'm hoping to kind of give, I think, primarily an update on Oregon Health Authority's response to changes at the federal level, and how we are monitoring that and where we see opportunities to make sure we are coordinating with bodies and commissions such as this one to provide you with the information you need to be transparent about what we're doing, and also just frankly to be transparent about where there are and will likely remain uncertainties given some of the unprecedented changes that we're seeing. So I think on that note, you know, every federal administration change presents disruptions on health policy as new leadership comes into place and with new ideas and efforts. And we are monitoring these changes closely. We are looking at both the administrative actions that are currently being enacted, as well as the conversations happening in Congress related to reconciliation and other budget efforts as those move through. In order to better monitor that, we've established a federal response planning team, which is staffed out of the OHA Director's Office and includes representation across all of our programs. And we are coordinating in that effort very closely with the Governor's Office and with the Oregon Department of Justice and other state agencies. So just to kind of give a sense of some of the activities that includes and some of the, I think, most recent actions that I'll just speak to. And I forget if I mentioned, also happy to answer questions afterwards. I think first and foremost, the action I think that's most central to the work is to make sure that we are publicly reaffirming the agency's continued commitment to our strategic goal and our goal, our central goal to eliminate health inequities by 2030. There is, I think, a lot of questions that are obviously coming up about what the actions mean and how it impacts that work. And so our commitment is to make sure that we are sharing resources and information to inform and provide reassurance where we can for OHP members, for other members of our programs that we oversee, and the communities that we serve and partners throughout Oregon. We are updating an external website regularly with those resources as we hear about them. And as questions come in, again, about what does this mean? What does that mean? Trying to be transparent about what we do know and what we don't. And that website is available on the OHA, and we can send that around related to the federal changes because it is going to continue to be the place that we push folks to for information about how changes may impact Oregon. There are no changes to OHP or other health programs at this time. I think that's an important thing, especially as patients are and members are thinking about whether to keep their appointments, whether they can continue to be seen. And it's important for everyone in Oregon and the community to access the healthcare and the services they need. So I think that's a message we want to make sure is clear and full-throated so that we are not seeing that kind of chilling effect that might otherwise be in place. In addition, we are finding opportunities to make sure that we're communicating with partners. So, you know, me here today is hopefully part of that, and we're doing this in various other tables throughout government to make sure that we are sharing this information, and also with our employees who I think you know, that those of you around the table who are and others can imagine that this is a particularly stressful time for public servants, concerned about the impact that the changes at the federal level may have on their work, on their careers. So as part of our planning and response, we're also, we have an internal webpage where we're making sure that we, trying to think of a better word than arm, but I guess arm our employees with information about equipping them, that's a better way, equip our staff with information and resources and make sure they're getting connected as needed. And hearing again from leadership about the commitment again to our overarching strategic plan and goals. So a couple of the maybe more specific actions that I think are relevant. And I'm talking with Jason about likely conversations that will happen at the retreat today, is certainly around federal funding. So I think we, broadly across OHA, and certainly within this body of work, see the federal government as a key partner in being able to improve the health and the well-beings of Oregonians. And so we are actively assessing how the changes at the U.S. Department of Health and Human Services are especially related to restructuring and funding changes might have an impact. I think the most recent, or I guess a recent announcement was related to restructuring at HHS that would consolidate a number of divisions. So taking it from 28 divisions down to 15, taking the number of regional offices which serve and are really a liaison to a number of programs that are operated at the state level. Those regional offices are transitioning from 10 to 5, and we're also seeing a downsizing of the federal workforce. The initial quotes were from 82,000 HHS employees down to 62,000. And again, those are folks that are both employed at the headquarters, but also through these regional offices as well. And so there are, thousands of those employees received those federal reduction in force notices. And it really is kind of an indication that the federal administration intends to further consolidate and in some cases eliminate congressionally authorized programs and drastically reduce the funding levels. I'll just point to recent media reports this week about what that kind of proposed budget would look like. And while that is for folks that follow federal appropriations, the president's budget is really a wish list of what the executive branch under a given administration is asking Congress for to operate the programs. It's not final. It needs to go through a process, but it's a good indication of where those priorities are changing and shifting. And I think we accordingly will be assessing what that impact could be. I think we're initially focused on how significant HHS cuts could affect the quality and the quantity of health services, of the public health infrastructure, and probably most importantly for this body, the scientific knowledge upon which our Oregonians' health and well-being relies. So the elimination of those offices or consolidation of agencies like HERC, like the Assistant Secretary for Planning and Evaluation, like proposals around the NIH institutes like the National Institute for Minority Health and Health Disparities. This will impact the scientific knowledge and health research that we rely on to operate and evaluate OHA programs. And so I think that will be and should be a part of the conversation about how our own approach will need to be restructured as we've come to or reevaluated as we've come to rely on those sources day to day. And it's just something that we all need to be kind of thinking about together. And I think some of those impacts will be fast when it comes to eliminating public health surveys or data sources. That will be, we're kind of seeing that already take place. But other impacts will be longer term. I think as the government's investment, for instance, in preclinical research diminishes, right? The government has an interest in taking on riskier preclinical research than necessarily the private sector does. And it's going to be years until we kind of see what the true impact of that is. But again, it's important to be thinking about that up front and how we might need to respond appropriately, expecting that could be, unfortunately, an impact of some of these funding cuts. On that note, we're also at the agency providing support for Oregon's participation in multiple federal lawsuits. So when there was an initial federal funding freeze in late January, we worked with the Oregon Department of Justice and the governor's office to provide information that supported Oregon's participation in the federal lawsuit, which did result in repayments or payments restarting and resumption of payments to our programs. More recently, in late March, HHS through CDC and SAMHSA abruptly terminated over $100 million in federal funds mostly through COVID era grants, but those that were still continuing to a number of OHA programs. Following that suit, or rather following that action, a group of states, including Oregon, also filed a complaint to challenge that cancellation of those funds. And attorneys general and governors from 23 states and the District of Columbia joined us in that. And ultimately challenging whether or not HHS lacks that authority to unilaterally claw back funds that states have already built health programs around. And it's not just the state government, obviously, in these cases that have built programs, but it's communities that have built that infrastructure and planned around that expectation as well. And so we were happy to see temporary judicial relief granted in that case in the form of a temporary restraining order, which just yesterday was extended for another 2 weeks as the case is fully decided. And just to give you a sense of scale, that sudden loss of funding and some of the things that it initially touched and is currently stayed. But that included grants to the Behavioral Health Division to help establish the 988 crisis line. It included a grant to our Public Health Division to establish a health equity office. It also included multiple grants to public health related to vaccine preventable disease work. And so, and adding laboratory capacity and basically doing a lot of things that we saw through COVID were desperately needed areas for investment in the public health infrastructure. So we will continue to challenge those actions. We'll continue to engage in full evaluation of the impacts of attempted funding terminations and other actions that could impact our programs, including whether they're legal, and remain committed to supporting evidence-based decision-making, improving the lifelong health of Oregonians. So I end on that note where it's not necessarily a great one, but it has shown that there is, I think, through our ability to assess what the impacts are, explain and tell that story, and really pull all the levers that we can to ensure that we can continue to serve Oregonians, to continue to utilize the resources that have been appropriated by Congress that Oregon taxpayers paid into, and continue to ensure that we are fulfilling our work, though it may be different or constrained in unique ways that we haven't faced before. But we are here in partnership with a spirit of transparency, and we'll get through it together. So thank you for the time, and I'm happy to take any questions back.
So if I understand you correctly, is this a condition of instead of doing more with less, we're going to do less with less? And specifically, does this mean that there will need to be some changes in the benefits that we're currently reviewing, and also some decrease in coverage?
Thank you for that question. I don't think there are any at this point changes that we see are necessary in that regard. I think we will continue to, as I mentioned, the benefits available to OHP members have not changed. The programs have not felt any direct impact. We, however, can't predict the future, and so therefore need to be, although we can see, and hear the direction of conversations in particular in Congress, and need to be planning for what those scenarios would look like, but don't have at this point a direction or an understanding that we need to change.
Thank you.
My question is more around information protection for the state level versus the federal level. What can we do to protect the programs that the state supports that maybe the federal programs do not?
Sure. I think it's a great question, and one that we're really taking case by case with the Department of Justice to understand where, and as you're speaking, I'm assuming the privacy protections and other things that may be in place to ensure that we are following all federal and state laws when it comes to assuring that we are following all best practices and requirements to protect data and to ensure that we are also following the law around our sanctuary state practices. So those are absolutely top of mind. I think to the extent, as I mentioned, that partners or others have specific questions about how that is being managed, we welcome those so that we can make sure that we are providing both on the public website that I already mentioned, which already includes information broken out by program, including the Healthier Oregon program and other specific service areas, what the steps are and what the state law is that we are relying on to assure those protections.
And is that available in accessible language to the public, or is it who's the audience?
Our audience for all of this information is the public. We've been working through the CPOP program and through our external relations division to make sure, and the innovator agents to make sure that that information is available and accessible, and we'll continue to do so as more information is able to be provided.
Thank you.
Anyone online have any questions?
The Innovation Center, any thoughts or any rumblings about what's going to happen with the Innovation Center?
Sure. So I can speak from prior experience, but then also what we've seen most recently. So the administration announced a number of models that were being that had already been in process of being tested or implemented, and the decisions around ending some of those earlier and taking some different direction on a number of models. And most recently, in the new executive order around lowering prescription drug prices, there was also an indication that the administration will be looking to the CMI authority to test additional models related to that, which is consistent with the first term of the Trump administration. It was consistent with the Biden administration that that was a particular authority of interest to address drug prices outside of the Inflation Reduction Act programs. I think that there has been kind of general criticism based on more recent evaluations from the Congressional Budget Office about the savings that are demonstrated through CMMI models. And so it is always a question, I think, about what is the right time to end models that are not meeting the mark. And I think the ones that were cut short are among those that were already reaching kind of the conclusion, as it were. I think what's really challenging, especially for those large scale health system organization related demonstration projects, is just the lag on understanding the impact. And I think more importantly, especially for this kind of commission, is the fact that it is really hard to test prevention-based models and see the impact on the timeline that would allow us to expand or demonstrate that they're meeting the statutory authority of improving quality without increasing cost or reducing cost without reducing quality. So I think those are just challenges that are presented, I think, perennially with the way that the CMMI authority is structured. And I'll say the one I was particularly disappointed with getting the cutting blocks that hadn't started yet was the $2 Medicare $2 drug list, which was intended to try to incentivize behavior change on the beneficiary side in terms of making it just easier to have a flat amount of a copay rather than for high value generic drugs, rather than having it change all over the place and be confusing for both the prescriber and the patient. So I'm hopeful that there will be other models that kind of move in that direction and look more, for instance, in the Medicare Advantage space, which is obviously now more than half of the Medicare program, and yet has not been subject to as many demonstration projects as fee for service. Continuing to think through what the methods for evaluation are when it comes to the prevention-based models, but also in Medicaid. So the authorities within CMI are very good in a complicated web with the demonstration authorities under the Medicaid statute. And that presents, I think, a continued area where there's just an opportunity to think creatively about how those authorities can be graded in a different way. So I don't think, I guess I'll end by saying, I think the cancellation of some of those models, I don't see as particularly surprising. And the indication that this is an authority that this administration understands and has utilized in the past. At this point, I just don't have a good sense of what those areas may be specifically. It doesn't seem like they've given clear indication at this point.
A question that may be hard to answer, and I have a guess as to the answer, but I'm curious. So, these things that are being cut, you mentioned the 988 line. I mean, my last patient yesterday was a suicidal veteran, and one amongst the many things we discussed was 988, and he had said, well, they're not, they cut that, and I thought that they hadn't. I thought they had saved it. But do you get the sense that there is a feedback loop available for, especially, critical programs that they'll listen to? There's this kind of move fast, break things approach. And I think the theory is that, well, if you push too hard, then you can reverse things. But is there a way to say, hey, no, this is, you're literally gonna affect people's lives immediately, not in a delayed way. Is there feedback being heard? Or?
I mean, I will say, and I kind of similar to what we'll share with our internal staff, is that as public citizens, you have opportunities to reach your congressional delegation, and I think those are opportunities that I know through other coalitions and private groups that are working in that way. I think the particular stories are always important for us to understand too, as the funding for some of the complementary programs to the larger scale federal programs are changing. I think 98 is a good example, right, where the infrastructure may be supported, but how are we, our funding change is going to impact the way that we make those that would benefit from it most aware that it's a resource that's available. Same thing goes for healthcare.gov and the Navigator programs and funding to those that are being cut. If we build it, will they come? We know that that's not the case if the marketing and consumer engagement and outreach programs are not fully funded. So I think raising those stories, sharing those with us, we understand at HA where we may be able to supplement or raise those flags. It continues to be important. Raising those through other channels are always available as well.
So I have a question that you may not be able to answer, but thinking about the proposed, well, what will end up being almost $900 billion in Medicaid cuts, and what the impact you see that, how we're going to address that. I mean, it's going to impact every state, blue, red, and especially thinking about the three populations, kids, adults with disabilities, and the elderly, how that plays out, what the contingency planning is here in Oregon, and how especially that's going to, the fact that we're moving towards CCO 3.0 in a time where there's massive change, how that all plays out. And if you may not be the right person to answer that, and there may not be any answers from anybody at this point around those things.
I mean, I think I would, on the first part of your question, definitely defer to our Medicaid colleagues on some of the specifics around scenario planning. And also to procurement, I'll just say, that the legislature at this point has been discussing the length of CCO contracts, and it's possible that there could be an extension, which would shift the timeline of the procurement work. And just given the current environment, our director, Dr. Hoppy, did provide testimony indicating support for that proposal to provide more flexibility, and indicating if the legislature provided that flexibility, that we would, the current contracts would, the intent would be to extend those for 2 years. There's also, I think, it's important that folks also realize that procurement's not the only way to influence the program, and that those changes can be, some changes can be implemented through contract language every year, which just brings an opportunity to make sure we have continued accountability and innovative solutions in the program. And so I think, again, having that kind of flexibility allows us to make sure that all of these factors are considered.
Thanks.
Thank you so much, Claire, for coming. I know we could probably talk a lot longer. I think there's probably a lot more unknowns than knowns, but we appreciate you sharing where things are at, and we'll look forward to collaborating as whatever comes.
Absolutely. Thank you for having me today.
Thank you.
Yeah. Right. So that was zooming out a little bit. We're going to zoom back into our main focus for the day. And Jessica, if you could, Jessica's away. Are you able to bring the slides up?
Yeah.
I want to kind of review the meeting materials that we sent out last week at a high level. And the structure of the day is kind of, we're going to do an initial review of what we came up with as staff. We're going to have some panel presentations, and then we're going to have lots of to discuss that actual document on the board. So the idea is to kind of give an overview of where we came from, how here, what staff came up with. Here's some perspectives from our colleagues in Washington and our health analytics team after lunch. And then over the lunch hour, we actually have some table discussions that we'll do that should allow you to process a little bit what you're thinking about with regard to any of the above. And then we will, again, wrap up with some table discussions and then bring it all back together and talk about next steps. So that's kind of the arc of the day. So we're a little behind schedule, so there probably won't be as much time to discuss what I'm about to share right now. But stay tuned, stay here. We'll make sure that it's time at the end of the day. So you may want to jot down notes or questions because we're going to get a lot of content today and see how we bridge that together. And Thursday, if you would like to join me here now that we have a seat, you're welcome. I feel terrible feasting in the middle of the fishbowl there. All right. So with that, let's go ahead and work through the slides. So again, we're going to keep the webinar muted except for staff and invited speakers. Those of you who are staff and invited speakers, feel free to come off mute and speak up or to raise your hand, and we'll do our best to make sure you get a chance to say what you need to say. We aren't having public comment today in this meeting, but we will have opportunities to comment on everything discussed here at future meetings or in writing at any time. This is a live recorded webinar. Members of the public can observe, and we welcome those who are observing. And the video will be posted online next week on YouTube. So let's go on next slide. So bathrooms, important since we have liquids here. Down the hall, between the elevators, and there'll be signs directing you to the appropriate restroom. Water, we do have some bottled water there. We also, if you have your own water bottle or if you have a cup, there's a water dispenser just across the hallway. We'll have a break at 10 o'clock and a break at noon and another break at 2 p.m. or thereabouts. And then finally, if you parked in the Liberty Center garage that I listed, Jessica has some stickers if you put on your ticket and they will validate so you don't have to pay. So
Jason, there's filtered water and you fill up your water bottle by the restrooms.
Oh, okay, great. So filtered water by the restrooms. Let's go, next slide. So we had the agency update. Again, I'll be reviewing HERC's role. Again, this is kind of what I went over earlier. Let's go to the next slide. So we're going to talk a little bit about our role within the Medicaid program. I felt like I need, even though this document is about decision standards, I wanted to start it with our context because decision making looks different in a physician's office with an individual patient than it does at a Medicaid policy level, than it does at a quality level, than it does at a commercial insurer. And so I'll talk about our role. So going to our statute, you see the references there. This is something I noticed. My first assignment in March of 2010 was to read the statute, and I just noticed this now. Number one is solicit testimony and information through a public meeting process. So finally we have Daphne dedicated to doing that officially, as she's done unofficially for years. So that really stuck out to me, that's what the legislature put at the top. The word evidence actually doesn't appear in the statute other than in the header, which is also kind of interesting. Now these, I've been a part of enough legislation that these things can be kind of accidental, but I found it interesting. The second thing is to develop and maintain a prioritized list of health services ranked by the importance to the population served. Importance is an interesting word, and it leaves a lot open to interpretation. We have our methodologies and our norms that we've built up, our policies we built up over the years, but that is the fundamental, that's most of our work, is to maintain that prioritized list now that it's been developed. And as a part of that, we have our clinical practice guidelines, aka guideline notes, group pairings, and statements of intent. And then we also have a mandate to consider both clinical and cost effectiveness using peer-reviewed medical literature. And that's a lot of what we're going to talk about today. Then we have our reports to the legislature and the governor. The prioritized list, of course, that has some new provisions this year with the impact on personal disabilities. So we'll be reviewing that biennial report at the May HERC meeting and has a section related to that. So we'll go over that at that meeting, but that's a new part of our mandate there. And then there's a reproductive services report we do related to reproductive services every 2 years. So that is usually more routine. It usually matches the USPSTF and the Women's Preventive Services. I always call it whoops. I don't know the way to pronounce that acronym. And then finally the medical technology assessments, which is our coverage guidances. Those more in-depth reports are also staff. I guess authority to do that. And those aren't just for Medicaid. Those are intended audience is all healthcare payers in Oregon. We know they're used in Medicaid. Doesn't do it in our work. We also have heard through the grapevine, that other payers are watching that. So next slide. In addition, this year we're preparing for the end of our 1115 waiver related to the prioritized list. As some of you may know, the bill that we at OHA had introduced to change our statute to reflect that is not moving forward. There's going to be a task force. Meanwhile, we're going to continue our work because our best guess is that the decisions we're making will need to be made anyway. But there may be some changes ongoing while we're just going to keep moving forward. So now we'll dive in. So that was kind of the introduction, our role, what we're doing, why we're doing it. Let's move into the decision standards. We're replacing, and we're going to go into history a little bit here, our current quality of evidence statement. I think it's 12 to 14 years old, and it has it focuses on study design and some other factors that influence the quality of evidence. It also lists some sources that produce high quality evidence reviews, and some of those no longer exist because time changes. The river of time flows on. It lists study designs in three categories that can be considered high quality and are preferred, can be considered lower quality and are often reviewed, and can be considered very low quality and are seldom reviewed. It also, in those lists, it mixes up peer reviewed research with payer policies and guidelines, and that's a little bit of a mismatch. So recognizing that, that's our current statement. It's on the website. It is, I'd like to see it updated. That's what we're hoping to do today. This is our prior attempt at standardization, and no, you don't have to read all that little flow chart. We're going to zoom in on parts of it, and I'll go charts in more detail. This was if you could stay on that slide, Liz. So this is an attempt in 2014 that the commission did to kind of graph out the decision process. You can see it looks very logical. Computer could follow it. But next slide. So first, we're going to look at the side of that. So this is a zoom in on the side where there is sufficient evidence. And so then it goes into, well, what is the effectiveness based on that sufficient evidence? So the evidence tells us how, what the effects are, but what are they? Is it more effective? Left side. Then you look at the treatment risk and say, well, okay, but is it better, is there more risk or similar or less? And then based on that, there's a strong or a weak recommendation to cover it or not. Actually, it's probably cover it if it's similar or less. There would be, if there's more risk, we would not recommend it. And if there's less or similar, we would recommend it strong. If, on the other hand, if somebody can keep that middle box for me, because similar effectiveness. So similar effectiveness to other alternatives for that treatment. Again, based on the risk, it's going to be if it has more risk, it's going to be a no. You can see this example, that was the case because that's colored red. If it's similar, then we look at cost. If it's less, then we're going to recommend covering it even if it costs more. If it's less effective, again, you look at the risk. And if it's similar or more, you do not recommend. If it's less risk, then you look at cost. Is it worth covering? And then finally, if it's ineffective or harms exceed benefits, none of the other stuff happens. We're not going to. So that's when we have evidence. Even that was not straightforward because they're not binaries. Things are somewhat effective. Things are somewhat risky. Alternative treatments have, less convenient or harder to access in different parts. There's just all kinds of factors that can't be shown. But you can see there is a logic to what you see on there. So let's go on to the next slide. This is the insufficient evidence side. So the evidence returns, let's say, a question mark and or shoulder shrug. And there are no alternative treatments available. And we have conditions like this, and I think we've talked about some of them in recent months. There's just nothing really out there, and the evidence for this, maybe it works, maybe it doesn't. Then we look, if there are effective treatments. What is that? There are no alternative effective treatments. If the service appears to be effective, based on the limited evidence we have, we would recommend it. If it's ineffective or harmless. So again, we're answering a question about evidence when there isn't enough evidence. That's an awkward position. It makes it difficult. So let's go to the next slide. Now this is the part of the family tree there with insufficient evidence, and there are alternatives. And again, there you compare the risk to the alternatives. You also consider on the right side, there's insufficient evidence, there are alternatives, and the treatment risk, if it's similar, then we get into, is the treatment prevalent? Is it standard of care? Is clinical research reasonable? Should they have been able to study this? Is it something you could randomize people to treat? You could get funding. If so, the idea was that there would be a higher bar because show us the research. But what we found back in those days, and I think Val is the only one, Val and Ariel are the only ones still on the team, although Ariel didn't work with coverage guidances as much. We just found ourselves revising the algorithm for each new topic. And
It depends.
And it depends on different things every time. And so I'll just read a little bit from the minutes. So in late 2012, there were discussions such as less risk for harm, but unknown effectiveness. There was discussion of standard of care and how to invest public resources and public dollars. The entire side of the algorithm in which there's insufficient or mixed evidence was felt to be risked for recommending coverage. So somebody thought, okay, let's just take that whole second. If there's no evidence, the conversation, not cover it. Perspective that was there. We've evolved somewhat since then. At least our decisions appear to reflect that. If there are insufficient evidence, how can one know if it's safe or cheaper? The middle avenue of the algorithm should not have coverage. So that was somebody taking a harder line and saying, we show us the evidence before we cover something. By January 2013, so a few months later, what about if there's unknown risk? That happens, right? If you don't know the 20-year effect of any treatment. Later in 2013, someone noticed there was a strong recommendation for coverage based on expert testimony, not evidence, and this expressed discomfort. That happened again in 2015 with a different topic. By March 2015, there was talk about using the algorithm more as a guide than a rigid tool. Later in 2015, we did some work with our colleagues at the center and developed the coverage guidance, the grade table that you've seen in our coverage guidances. And we'll go into that next. So let's go to the next slide. Check out for time 10, 13. Okay. So this is the grade table. I excerpted it there. You can't see all of any given part of that, but just briefly to review. The top left corner there with the dark blue, the teal, and the rationale there. So there's a coverage question. There's a recommendation. We recommend coverage of XYZ under PDQ circumstances. And then there's a rationale where we say why we do that. I will say as a member of staff, and I think others will agree with me, those rationales can be the hardest part of our work. Like we know what we're doing, we know what we want to do. Sometimes it's really hard to say why. And that's an interesting process to encounter cognitively, for at least for me it is. But this forces us to do that. And that's the bottom line. It's up front. It's actually the end of our process because we're looking at the evidence and building that, but we're presenting that up front at the top of the coverage guidance. Then we have the evidence table, and that's where the bubbles are at the bottom. We have quality of life shown there, but there are 5 outcomes. And you can see that for this one, there was low quality, that's 2 bubbles, and mixed results. So sometimes it works, sometimes it doesn't. We don't really know, but you know, we have some evidence, and that this was continuous glucose monitors. You know, that's different outcome, and you can get mixed among the 5 outcomes, one of which is usually harms. You can get a different picture. You can get all empty bubbles saying, we just have no idea. And sometimes that's a limitation of our research resources. Sometimes it's just the evidence is really there. And then below those 5 bubbles, you see the things on the right side, the balance of benefits and harms. That's our attempt. That's also a tricky bit of writing. Balance of benefits and harms based on those 5 evidence rows. Then our gestalt sense of the resource allocation. And that is just more of a, you know, our staff opinion and resource, you know, the fees associated and potential cost offsets or associated costs with a given service. And then patient values and preferences. We rely on our clinicians a lot for that. We also know from experience what the public testimony has been over the years. And in general, we know that people prefer safe, effective, convenient services with no side effects. And they don't like any of those factors to go the other way. And so, you know, a lot of it is just applying that to a given treatment. But sometimes there are you know, other values that come in, and we try to list those there. Different risk tolerances, for example. And then other considerations, that can just be any contextual information. It's not available in rural areas, et cetera. Patients find it convenient, those kinds of things. So that's a very quick review of our grade table. And those of you on HERC, those of you at EBGS, that's your bread and butter. Those of you on HERC will see, and BBBS will see one of those in May. In June on sleep apnea. So it's your requests.
Question about that. Going back to the previous slide. So we're talking about balance of benefits and harms. So one of the things I key in are actual health outcomes. I'm assuming that the benefits are included.
Yeah, that's a summary of the health outcomes.
Okay.
Then we've been discussing this for a couple of years as we've had time at the HERC meetings. It's been difficult. We discussed it over 2 years ago. We discussed it at a meeting last fall. That's led to our discussion here today. We've heard you say guidance to help with consistency when the evidence is limited, because that's a hard space to be in. I think you can see why that's a hard space from the discussion, this presentation. And then also we heard a request last fall to consider the possible role of claims data or inform our decisions. We have a panel on that this afternoon from our colleagues in health analytics division. Before I go on from that slide, is there anything else anybody wants to put on the table in that category?
I would just like to elevate the work that is going into the public comment and your acknowledgement that it's at the top. And the only place that I see that we're looking at the consumer is in that one value and preferences. It didn't make it onto the decision tree because of the evidence. But when we are in these gray areas, I think understanding the people that we serve is an opportunity for us to elevate their voices.
Okay. Yeah, that's part of the document, which we'll get to in a minute here, but I recognize your place. It's just one part of that grade table. And so maybe there are ways we can adapt that or make more effective use of it. Anybody else?
And consumer voice is kind of upstream a little bit. We'll hear from people about something that they want reviewed. So how do we just select topics? A lot of those come from, things that have come up through public comment.
Yeah, but I think if we can match that public comment with some of the analytics happening in our population, then we can maybe have some validation on where there's an even match or not. And I know there's going to be still a lot of gray, but there might be some wins in there where what we're hearing and what we see, it actually align.
I will have a follow-up comment to that. I like what you said. And what I would like to see more of is standards, for instance, United States Preventive Services Task Force guidelines being part of that type of paradigm. So we're looking at what are the standards that are based on some validated information, patient input, and clinical data. And if there's a way to align those, I think that really would make a big difference.
I think some of that's in the structure. It's a grade-like structure, but the thing that the task force has they have an easy out in the sense that they can issue an I recommendation on something and they can just say the evidence doesn't tell us what to do, so we'll just give you an I recommendation. And I don't think we have that out.
Well, actually, a few years ago, the EGS did say, we're just not going to decide, not evidence. Went to HERC said, yes, you will. So let's go on for now, but keep those thoughts going. We'll come back to them this afternoon. So HERC's function, again, we discussed that, the high level meeting process, there's a description of that in the document. The decision point of, does this need a coverage guidance? a lot more resources go, we can only take a limited number of those each year? Or is it just an issue summary that Ariel's bring? And if it is an issue summary, is it a 5-page one or a 2-page one? Or is it a line on the straightforward table? Within that, regardless of which pathway, that decision is based on the level of controversy, the relative cost of the item of service, the risks associated with under or overutilization. And then it's also informed sometimes by internal claims utilization data. Let's go to the next slide. This is the meat, I would say, of the evidence portion. The decision framework. We have 4 questions identified there that I think encompass a lot of the discussion. I don't know if it's 100%, but it's probably 90% of what I hear at a given for BBVS or EBTS meeting. Are there clinical meaningful benefits? Do the benefits outweigh the harms? Is it equal or better value than covered alternatives? Are there important effects on health equity? Now that, and what are those? And is it health equity? Like that sometimes can get to be a discussion too. I think that one's maybe a little less straightforward than the others, and it's one honestly we struggled with as staff to know how to formally incorporate because it is so contextual. So I welcome discussion on that today. To answer those questions, we have 4 sources of input, and I want to give credit to Marcus and the center staff for developing this diagram and leading on this portion of the document. Peer-reviewed scientific evidence, that's in our statute, clinical guidelines, clinicians, and you see those referenced in the issue summaries and coverage guidances, and you saw that in the current quality of evidence statement. Then there's public testimony from members, families, caregivers, and advocates. See that in many of our meetings, and that's an important part of the process. And then other health insurance coverage policies, sometimes we model on those, or we look at those and say, well, that doesn't look quite right for our context. We'll take that and we'll tweak it. I know that's an important resource that we rely on. It's also kind of a, this works in other contexts, might it work in ours? And I think Ariel would say sometimes she gets good citations from those too, right? Yeah, go ahead.
I just make a minor suggestion for just in thinking about this. Clinical guidelines and clinicians are listed together. Depending on the guideline, many clinical guidelines would include a lot of the other stuff, the scientific evidence, the better guidelines would be evidence-based guidelines. Clinician experience is also an important thing, but I think it's a separate thing. And I'm bringing that up just because it may be useful for us as we, discuss later today to think about clinical experience and what its role is. How do you assess it? When is it important on its own? When is it less important? That kind of thing. I think it's a pretty nuanced thing, but I think it's its own thing.
So Marcus, let's revisit that. Let's make sure to come back to that because it is something we thought about a little bit. And I know Marcus thought about it, but I want to make sure we get to our Washington colleagues and the presentation.
Quick question. So on page 1, under the draft, internal claims utilization data, is that included in the other health insurance coverage policies, or where is that in?
That's a good point. That's not really there. So that's a potential addition. Did you have a place to put that with?
That when we talk about it, and again, it's up to the group. It was used to help determine whether something would be an issue summary or a coverage guidance. It was used kind of upstream of the making the coverage decision.
Yeah, okay. We'll discuss that this afternoon, the reasons for that. Thank you.
Thank you.
My comments super quick. It's just along what you were saying, Devin, what I've been seeing is maybe there would be a spot for a clinician advisory group that would help on that lower bar. Because that's what I see happening with a lot of the work that you're doing right now, is that we're going out and trying to get that feedback, but it's a little bit more powerful than an expert or an individual experience if you can make an advisory group around it.
guys point out that you already have those people?
I agree, but we don't have all of the experts. And so for a lot of the work, we're going out to specialties and trying to get like critical mass or contributions from them. So that's what I was thinking about.
Okay.
Like the ophthalmologist.
Ophthalmologists, yes. Or allergists, yeah. Okay, and just in the interest of time, I want to get through all this at a high level. We are going to dive into many of these issues more. Sorry. Oh, Ben, I'm sorry. Yes.
Just very quickly, this is my job here. The evidence base for pediatric care is significantly different than the evidence base that exists for care for adults. There are very few USPTF guidelines for pediatric care. Half of the drugs we use are off label. I just want to make sure that as we're thinking about standards, I mean, we have to think about populations differently. I just want to make sure that that's not a hard conversation.
Well, then we have EPSDT for peds too. So there's lots of.
That's a whole other issue.
Streams.
Okay, Leslie, very quickly.
I was also thinking of the pediatric situations that we've encountered where there isn't evidence and there's not going to be. Like, you just have to have that as something that we all agree on. But I also wanted to talk about the other health insurance coverage policies and really wanting to make sure that when we are talking about them, that the committee fully understands the processes those other health insurance organizations or states went through to be able to do that, because there have been conversations here where, you know, I think all of us naturally want to find a way to, well, I'm pretty transparent. I always want to cover things. That's what I want to do, right? And so when you hear from other states and they've done it, there's always this idea like, oh, well, they did it, or, oh, they don't. And all of a sudden you're in a very subjective place where you're putting your actions upon something else you don't fully understand. So I think if we are, when we look at other health insurance coverage, we have to be really careful to understand what are the processes they went through and what are their values going into that. Just because there's a group that might have endorsed it doesn't mean that we would match their values. Just because there's a state that didn't cover something,
So
they might have had something else going on.
and there's a section on the document about how we use that. And if that doesn't look right, let's talk about that this afternoon.
Yeah.
So let's go ahead and move on here. Next slide. But yeah, there's a lot on that slide and we're going to spend more time with it. These are some of the questions we asked about scientific evidence. I'm not going to read all those. I think you've all seen those discussed in our meetings. So we also do include in the document a list of typical study designs that can be relied on. It's starting to a little different current quality of evidence document. Next slide. This is a version of the evidence pyramid that Marcus found for us. You can see randomized controlled trials at the top, cohort studies, case control, case series, and then see the handle of the magnifying glass there, systematic reviews and analyses, which help us grasp when it's too much to put in our brains at one time because of multiple studies. I think I have that right. The reason for that image. And then, of course, you know, the traditional experiment is also expert opinion guidelines at a lower quality clinical consensus. So, and the lines are wavy because there's different qualities in each of those strata and they overlap. Is that what you're saying?
A really small, really poorly done randomized trial may offer less good evidence than a really big, really well-designed prospective cohort study. So that's just meant to communicate that.
Right.
Can I ask a question? Is like FDA approval or New York State Department of Health approval, any of those considered when looking at technologies?
We do bring that in. That's not listed on the document. That's a great call out. Regulatory approvals, and those may mean different things. They don't always mean it's correct. It's great. They mean very specific regulatory things. So yeah, we have to pay attention to that. Okay, let's see. Next slide. This slide is on the voices of members, families, and caregivers. We've already discussed that. These are the roles I've seen them perform over the years, suggest topics for review. If they're aware that what they need is not covered, they come to us, we review it. Provide information about how services are accessed and delivered. Hey, I know you all cover this service, but I can't get that in Madras or whatever community, or it's inconvenient, or a lot of red tape, whatever it is. They also provide information on values and preferences for certain treatments, services over others, their experience of using the services, accessing them. And then organized advocacy organizations also, combine the experience of lots of different people. And sometimes they can present information in a way that is useful to the group.
So Jason, would that include, I wrote that as I was scribbling.
Yeah.
So recently, have OHA and through the 15 waiver, accept traditional health knowledge keepers, health workers, as well as tribal-based practice. So that would probably fall in this category here for information, because you're not going to find cohorts that do that, right? So those are within communities, and some of those are large communities that are probably larger than some cohorts that you have with thousands of people that you practice on.
Well, that's an interesting thing. That process, I actually don't know that much about it because it's a different arm of the agency and a different process and a different approval. So those things are kind of happening over here. And I think there's lots of reasons for that, political reasons, but also because you're right, the kind of evidence base and experience and tradition that supports those practices, I think, doesn't really fit our tools and lens. But I do think there are some similar things happening, outside of tribal communities. There are other communities that have traditions and practices that are really important, religious communities, cultural communities. And so those things do come into we had the discussion on circumcision a few months ago. And that's just one example of that. Doulas, yeah.
There is an every 5-year Oregon Health Authority Public Health State Health Assessment that comes out. Is that something that could contribute to looking at what needs to be evaluated?
I've looked at those a couple of times. I have had trouble connecting those dots, but if there's a way we can do that, I think that's something worth discussing. I don't want to take time now because we need to get to break, but let's keep a note of that. Because that is a very big picture look, and we're probably some little part of that picture that they have there. And then the other coverage policies, this is probably the smallest part, I think, of our decision standards, but we wanted to be transparent about it, that it's a factor. Those often provide context, like what are the pieces of information payers have as they make decisions, example criteria, sources for the evidence used to develop those criteria. That's sort of what we referenced in that section. Questions that I'd like you all to be asking throughout the day as you hear the presentations. Do the standards like documents support your task? Is that something we can tie back to guide us when we have difficult decisions? Do they accurately reflect how decisions get made? Do we need to adjust what we're doing? There's going to be kind of a two-way conversation there, right? Are the standards right? If they are we living up to our bills? Do the standards provide a useful guide that can support more consistent decisions? Are there opportunities to incorporate equity principles? Again, that it's a broad concept. To be useful, I think we would need to break it down a little bit and figure out how equity applies in the things we're doing, or does it show us there's something else we need to look at that we're not looking at? And then, do we need to add more, edit more, delete from this document to have a decision guide that HERC can feel good about endorsing? And then we bring that to a future meeting. We'll have a next step session at the end of the day, give some direction to staff, then we'll bring it back to a future HERC meeting. So with that, I think it's time for a break, and then we'll have our colleagues from Washington share with us about their experience. A lot of the same issues, I'm sure, but a different context and maybe some new insights. So See you all in about, what is it? 10 minutes.
Yeah.
Good job.
Oh, sure. It is fascinating. And it's.
Yeah, I had a turnaround.
It's really nice. Some of us.
There's like something.
Would be an acid. And
Oh.
I think all that-
Oh,
It's just such an honest.
I'm very slow.
So
the HDA program and policy for that.
Okay, I'm Melanie Golub. I work with Josh. I am the Health Technology Assessment Program Manager. And just pretty much kind of connect all the pieces with our program and our committee, which is now I guess to HERC. So yeah, and I think it was brought up earlier, but our process is very, very similar and we struggle with a lot of the same things that this group does. So looking forward to the discussion.
And is it possible, I see Dr. Franklin is on, is it possible for Gary to introduce himself?
Is it possible for what?
Yeah, Gary, you want to introduce yourself?
Yeah, I just very happy to hear you guys. Really impressive program, and I just great to see our partner state doing so great on this stuff. I do remember years ago about the priority list, which was not, I think it was difficult to deal with a long time ago, but you guys really have upped the game tremendously. It's really great.
Thank you. Dr. Franklin is the Chief Medical Officer at the Department of Labor and Industries. We'll talk briefly about the impacts that this program has. Oh, and Judy's there too.
You want to introduce yourself?
Sure. I'm not going to be able to stay the whole time, but I'm Judy Zerzan-Thule. I'm the Chief Medical Officer at the Healthcare Authority, and I long admired this program from afar, and now I'm a part of it. So it's good to share what we do with our sister state, Oregon. And yeah, I look forward to some good conversation. Thanks.
So again, we're from the Health Technology Assessment Program in Washington, and HTA program is within the Healthcare Authority, and it's managed by 3 staff members. This includes myself, Melanie, and Val Heyman, who is not here today, maybe online. So some quick background on why we have the state's program and where it's housed. So the state's Healthcare Authority is the state's largest healthcare purchaser. We purchase healthcare for more than 2.5 million Washington residents through these programs, through the Apple Health or Medicaid program, through our Public Employee Benefits Board program, and through the School Employee Benefits Board program. Our agency budget in the last biennium, you can see here, it's significant. It was close to $34 million. Significant, most of that, or more than half, is Medicaid. So our approach at the Healthcare Authority within our division is, towards clinical quality, is one, evidence supporting standard of care. It includes clinical decisions across both Apple Health, across these programs, PEB and SEB, or the public employees or school employee programs. And we work to ensure that the health plans use science-backed standards to provide the most effective care. We design innovative pilot projects for critical issues like chronic disease management and response to the opioid crisis. We purchase care using standardized methods to improve efficiency while increasing the quality of that care. And we aim to measure and improve clinical quality using national and state measurement systems and analytics. And so within that context, we'll move on to this, the Health Technology Assessment Program. So, the rationale behind the HTA program starts with the value of the care that we're purchasing and the outcomes that we achieve from that investment in our healthcare. And as we all know, that the United States spends a lot of money for maybe less return. That outcome there. And there's a lot of inefficiencies, and part of our, our aim here is to make the care that we purchase result in higher value, more efficiency in the overall system.
What's the blue and purple and the larger parts of the pie?
The blue, unnecessary services, and the purple, excess administrative costs. So this is a slide that provides even, getting closer down to the evidence here and why we really need to have programs like this.
As far as federal oversight goes for various technologies, including drugs, medical devices, authorized through different federal regulatory frameworks, and then medical procedures, there's a pretty big difference here in what level of evidence is required to get something to market. So drugs have a pretty high bar, and it's intention of this slide is just to say, look, when you look at medical procedures, there's really no regulatory requirements there for procedures. And then for 510K devices, which are kind of the lowest regulatory framework, there's substantial equivalence, really based on engineering performance. There's not necessarily going to be a mandated evidence base for these things. And yet they're ubiquitous in the marketplace, and payers are asked to provide coverage for them, and that there's frequently a lot of uncertainty about the safety, effectiveness, or value of those. And then the higher level for medical devices is the pre-market approval process, where there is some requirement for some study, but again, it's not the strength of what's required for drugs to get to market, and drugs have their own issues, even once they're in the marketplace. So this kind of sets the stage for, why are we reviewing the evidence for many things. Next. So the background on our state program, it is a legislative program. It was established in 2006. The bill at the time was called House Bill 2575. It created the program largely as it exists today, to use an evidence report and the clinician panel, much like your commission, to make coverage decisions about whether agencies should pay for certain medical devices, procedures, and tests based on the evidence of their safety, effectiveness, and cost effectiveness. And I think at this point we'll transition, and Melanie will cover some more detail about our program, but we can provide a lot more detail to your questions you have.
Yeah, so this is getting down into kind of the main parts of our HCA program, which separately we have the assessment part, which we contract with the external evidence vendor, the Center for Evidence-Based Policy being one of our evidence vendors. And then on the right-hand side, the evidence-based decision-making, that's where our clinical committee comes into play with all those different factors that you see there. So if you go to the next slide, we'll get into kind of what those are. So again, we have a clinician panel, and then we have the evidence vendors that we contract with to create the evidence reports. And the idea of those reports is these rigorous systematic assessments, so very much systematic review. And then clinician panel, which is our health technology clinical committee, which is also made up of varying providers, chiropractor, we have nurse practitioner, anesthesiologist, we have naturopath on there. And then the decisions that come out of these public meetings, Medicaid implements them when feasible. Oh yes, thanks. This is just kind of a flow of, okay, sorry, there's the animations, but just showing kind of the HTA program is sort of the in-between, the firewall between the technology assessment centers and our health technology clinical committee. And so this is just kind of showing how those interact with that big picture evidence appraisal that happens, showing, sorry, just for a second, just showing what I was discussing, that the technology centers do the review and then the health technology committee makes the decision. So this is just kind of big picture again, how our process works from technology selection to development of key questions. The report is created, and then there's that big public meeting, and then the decision is finalized. And if you just click next, then you'll see that there's public comment at many steps along the way. And actually, there's one after the decision is drafted and before it gets finalized as well. So many opportunities for public comment, in addition to at the meeting itself, there's opportunities for live public comment. So yes, we try to engage with the public. So And these are the main attributes that our program focuses on, that transparency, again, many opportunities to give public comment, but also it's all published on our website as well. So what those criteria are, what the reports are, and the public can weigh in on those things as well. And then we have that rigorous systematic review that's independently done by our external partners. And then that independent decision-making through that transparent public process where the decisions are focused on evidence. And this is kind of just, again, the flow and how it works. The topic gets nominated, it gets reviewed, that public input, and that happens as you usually select technologies once a year, but that can happen if there's a petition or other reason to select a topic. That can kind of happen at any time, but we'll do a horizon scan once a year. And then the time frame for the assessment report is usually about 6 to 12 months. So it's not, as you know, it's not a quick process. And then for the clinical committee, we meet about every 2 months or quarterly. We have an annual retreat for our committee as well. And then the decision happens within 1 to 2 years. It depends on the group implementing that decision on how long it takes. And then this is a slide showing who implements those decisions. So within the healthcare authority, it's Uniform Medical Plan, which is our public and school employee benefits programs, and then labor and industries, the workers' compensation, and then Department of Corrections, the corrections healthcare will implement the decision as well. And that's just within their statutory framework. And then if you just keep going to the right, so this is just to kind of show you that what part we're going to focus on. If you go to the next, this is talking about that horizon scanning for new technologies, and that happens annually. And then the re-review, we re-review topics as needed. We are legislatively mandated to consider them for re-review at least every 18 months. There was I guess that was 2 years ago now, a bill passed that we have to consider the evidence every year for those on prior authorization. So that's kind of a new thing that we're working with. So much. So still figuring out all the nuances of that. And then, as I mentioned, groups can petition to have a topic re-reviewed as well. And then the director of the HCA makes the final selection. There's also the option, if it doesn't get selected by the director, it can go to our clinical committee to get selected to re-review as well. Key questions. So that is like how these are picked for each topic are again mandated by the legislation. So safety, efficacy, and cost effectiveness. So that just gets into more specifics of those, but those are developed with our technology centers in collaboration with HCA and our medical directors that weigh on the program. And this is talking about the report itself and how the report gives greatest weight to valid and reliable evidence, which is as it should be. And then the point of those is to answer the key questions. Good. And then this is about, again, what I mentioned before, that it's 11 members from a variety of different backgrounds. We have for each topic a non-voting clinical expert that's sort of a guest member on the committee. And it's someone with specific experience in that field. So for acupuncture, we had an acupuncturist as our clinical expert so that it can answer specific questions about that particular technology. So it's been really helpful to have those people weighing in and giving input. And there's certain conditions to them being on there that they can't have major conflicts of interest. And we also try to make sure that they're not very much in favor or against the technology in one way or the other. So they're not going to try to bias the committee. So that's what we try. It doesn't always work, but that's what we attempt to do. So go to the next. And this is what comes out of that is, again, that coverage determination. The three options that the group has is covered, not covered, and covered conditions. And that happens in an open public meeting. The other evidence that's considered besides the evidence report is information from state agencies, those public comments, and as well as national coverage determinations and guidelines, if available. And then at the end, they have a draft coverage determination, and that goes out for public comment as well, and typically gets finalized in subsequent meeting. There's also that opportunity for public comment that might end up affecting the draft coverage decision. So, and then after that, then this is an example of a final findings, what it looks like, how we write it up. We post that on our website as well, and then it gets implemented by the different programs. So our particular program is just concerned with, the final determination, but then the implementation happens separately. Thank you. And this is just, again, an example of our HTA program webpage, which we can also send that out as well. But so it has all of our policy decisions, and what that example is over on the right is kind of what's happened to that point. So as you can see, there's the original assessment, and then there's an updated search, another literature search, and then before it got re-reviewed more recently in 2022. So I think that's about it. Happy to answer questions and the questions you have available. Thank you.
Why is it called why is technology in the title?
Health technology assessment, because ours works with the technology, and then we have a separate pharmacy and therapeutics committee that does the decisions for drugs.
But you are doing medical care, is that correct?
It's technologies and treatments, yeah.
Yeah, health technology assessment is a kind of a field of study, and the technology refers to all healthcare services, not just like our phone, like this kind of technology. It kind of refers to drugs, devices, and services in general. It's kind of a term of art, which can be a little confusing.
Yes, it is confusing.
That's kind of the research field industry term is health technology assessment.
Yeah, to make it worse, our statute says medical technology assessment, which is a variation, and then we don't even call it that, we call it coverage guidance. So it's
Well, doctoring and care.
okay.
Yeah. Why you outsource or contract out the evidence reviews, how that's worked for you, how do you avoid, conflicts there with that process? Is your staff who does it be stable? How it thinks about that?
Yeah, so that was legislated. The program was drafted into legislation in 2005, 2006. The idea was to not have state staff involved in assessing the evidence, to make it as independent as possible. And so it was put out so it's directed in the law to have contracted health technology assessment centers. So we do a public contracting process. We're actually in the midst of it right now, re-upping, seeking contractors. We've been through, I think this is our fourth cycle of contracting for, and so we contract with groups like the evidence-based practice centers that HERC contracts with. And, the Center for Evidence-Based Policy has been one multiple times, and maybe consistently through the program. We've had currently have another APC RTI is contracted, and a local firm from Washington is another current contractor. So that's the reason, basically, it's a lot. Yeah, and so the staff have been extremely stable, and we haven't really we've had some years ago conflicts where when industry was more involved in our program on certain topics, approaching the centers independently and not going through the state program. And that's, that's the only friction we've ever really experienced was people trying to, influence the process from afar.
Right, yeah, okay.
How expensive is that?
How expensive is that? That's a great question. I don't have a summary and average of what an evidence report costs offhand, but I will say it's not inexpensive. It's usually $100,000 to $200,000 per systematic review, depending on the size of the topic. Sometimes it's less than that if it's a small re-review, but it is not an inexpensive process.
So would that fall under the purple piece of the pie?
This makes it could be very high value.
So my question has to do with when something comes before, let's say it gets to the clinical committee. And as you heard us struggling with the issues like, well, there's not great evidence. Do you all have a rubric similar to what our amazing staff has developed in terms of this is the, the strength of the evidence, and it's sort of like it's like a nomogram or a way to go through it in terms of, okay, this is how much we're going to put member voice or whatnot. And also, sorry, side question, how do you factor in also the financial impact of that? Because I think that is something that is interesting, that like that's very specifically called out, which is not part of what this board does. Sorry, that was like two questions. One, is there a rubric? Two, how do you put the money piece in there?
Yeah, and so in terms of the rubric, yeah, it is very similar because it is about the safety, efficacy, and cost effectiveness. They have voting questions. There's a decision aid that was created based on the GRADE evidence decision framework. And so we've, as meetings have moved virtual because of the pandemic and they've stayed mainly virtual, we've created voting, kind of a voting slide deck, and then incorporating some voting software to walk them through sort of that decision and thinking through the sufficiency of the evidence. And the committee actually at their last retreat voted to kind of add some nuance. So, is there sufficient evidence and what's the confidence in or, in that sufficiency? So yeah, they do end up kind of getting very specific in terms of the evidence and walking through that. In terms of the cost question, were you gonna?
Sure. So if there's peer reviewed cost effectiveness research, we always hope for that, but there really doesn't exist. But our contractors are directed to seek that out. And then even when they do find things, there's often a very strong conflict behind that or funding bias potentially. So we don't see a lot of great cost effectiveness data influencing the decisions. And it is, I think you may have experienced this when you put a number on something, it's really easy to gravitate towards that. Like if you see an ICER that says, oh, this is a pretty good value, that number might start to supersede what's actually behind that, all the assumptions leading to that. And so we try to be really careful and make sure that all that's caveated when that information does exist. Our state agencies, we have a tremendous amount of utilization data. And we struggle, I think, when we're really interested in the conversation this afternoon, sometimes with summarizing what our true utilization experience is. Despite having all the data, it's difficult sometimes to identify the episode of care and what the real cost is, and to align that with what you think it should be based on other factors. So at times that's very influential in the process, right? If we know and can demonstrate what things cost in real terms, that can be, that's a good thing to consider. But again, we, depending upon the topic, it can be difficult to get access to that piece.
Thank you.
We'd really like to have it though.
Yeah, thank you so much for this presentation. This is amazing to see what are the similarities and what are the differences between Oregon and Washington. Maybe because I've been engaged in this work for a while, something that I've been mulling over is how to make sure that our decisions are kind of consistent over time. And so as I was looking at this figure, and Liz just serendipitously put it on, it actually uses the term precedent. And I would be really interested in whether you have any tools or how you have systematically thought through, like, how did the decision get made in the past, and then does that influence, if at all, how decisions are being made in the future when we think about how people change on boards, leadership changes, evidence changes, like how do you ensure that you're following precedent?
And that's a great question. And that's actually something that we have struggled with as well, just because you're right, community composition changes. They always used to meet in person, and then some of that has changed as it's moved virtual, and how do you maintain that consistency? So one thing about our program is there's kind of a mandate not to rehash previous evidence. So like if the evidence hasn't changed, they can't kind of go back and re-deliberate a previous decision. But in terms of consistency, that's what we've been trying to do, is sort of moving this grade evidence decision framework into more of like a virtual environment, is making sure that the decisions are evidence-based and essentially reproducible in that way. But in terms of adhering to previous precedent that was set, we do keep a transcript of the proceedings, so we can kind of go back and refer to those. But that is something that we're kind of looking to improve upon, as always on the field.
I don't really.
Just something to add directly? Yeah, do you want to say a little bit more about your decision framework, the questions that the committee cranks through?
Sure. So our decision aid, as Melanie described, it's based off of grade, and then I think it has evolved a little bit away from that. But the committee will, typically we ask them to look at the outcomes that we have pulled from our report, right? So what outcomes have been reported? And I think different from your process, from what I've understood, we have not limited outcomes. So our vendors, we don't say these 5 outcomes. It's basically as many as they find, given the key questions and given the limitations on the study design, the study type. There might be many outcomes described, and so we will pre-fill our decision aid with the outcomes, and the committee will stop and look at those outcomes and discuss, like, are these the outcomes that you're concerned with? So this was part of their process. Are there outcomes that are not here that you wish were here, or that we missed, that we didn't adequately report? And we'll go through that conversation around the outcomes for safety, outcomes for effectiveness, outcomes for cost effectiveness, and then we'll move into a voting phase of, as Melanie described, which is now done anonymously, right? So they don't know how each other is voting. We used to actually do this holding up hand cards in the physical space, so you could actually see how others were voting around you. And now this is all, you don't know what the vote is going to look like once you vote. So that has been a really dramatic change, I think, to have voting that you're voting on your own, and then you're seeing the result of how you're calling. I don't know, Val, is there other details that you're curious about? If we go through this is a non-binding vote, we call it, on the evidence. Like, what's your sense of the evidence for safety, efficacy, and cost effectiveness? And then we also have a little part on special populations.
Yeah, I would just also say, for clarity, that you don't generate grade tables for every outcome. Those are prioritized, but you do get reports that give you some subsidiary outcomes as well.
So is that, just piggybacking on that, is that why your reviews take so long and cost so much?
Yeah, so they don't take that long. Yeah, they're expensive, I think, because the quality that goes into them is tremendous. no stone is left unturned, and that's how the program is designed, right? We weren't, we may evolve in that direction, and we've talked at times about more targeted reviews, and we've actually started to do some more targeted reviews or re-reviews in the interest of quicker, more efficient updates.
Yeah.
Especially areas where there's not, we know it's not like, this is not a wholesale change, it's a very targeted change. Yeah.
To add to Josh's point too, the length isn't necessarily because of the reports themselves, it's because of these mandated public comment periods that are written into our law. So we have to have those. So, you know, there's certain minimum timeframes that we sort of have to have to allow adequate time for public comment.
Last I counted, there's a minimum of 107 days of public comment. During the quarter.
For every topic.
Every topic.
107.
Dr. Steinberg, and then Dr. Lovely.
So,
Comment in the chat as well.
Dr. Steinberg.
so thanks for the presentation. Really interesting. I mean, I'm actually kind of struck at how similar the approaches are. I mean, even the outcome approaches, I mean, we limit them, but we also, they're looked at. And I think in the end, it kind of probably ends up being very similar. So you must deal with the same thing, which is that there's a lot of things that you don't get a clear answer for through the evidence. So how do you deal with it?
As well, you know, we do have, again, that sort of decision hierarchy where if there's, again, it actually says in the law, if there's insufficient evidence, you can't cover it, you know. Granted, that does.
Just to clarify, so literally, if there's a thing that has not been studied adequately, you cannot cover it by statute.
It likely wouldn't have even gotten selected as a topic just because of that creation of that evidence report. You can't really, you know, create an evidence report with no evidence. So yeah, it likely wouldn't have gotten selected if there was no evidence.
Okay, that seems different.
And well, that's one big difference, I think, is how many topics a year about do you guys do?
3 to 6 a year.
Yeah, I think there used to be more, but we also have separate policy creation within our division for sort of different topics that are less controversial or, you know, where the evidence is more.
So what happens to the topics for which there is, you know, not great evidence? Where are those decisions made, or are they just not made?
So for the HTA program process, so we have a group called the Agency Medical Directors, which is our consulting group, the participating agencies. That group will look at potential topics and decide what they think is a good topic for this process, right? This is not a fast process. This is not an inexpensive process. This is a process where if there's controversy or uncertainty, but there is evidence, this may be the way to go. Or if there's large populations impacted or large state expenditures likely, we will use this process. Otherwise, the agencies have full authority to make coverage decisions on a daily basis, right? There's hundreds of things we're dealing with all the time. And so.
So who is that? The agents, who in the agency is doing that?
Right. So where we work, we have a team of clinical policy staff that manage billing guides for Apple Health, for Medicaid, for example, and they are charged with making individual policy. So we have an internal policy engine in groups that look at those things.
Gotcha. Okay.
Policies in the
So it's
industry.
public process though.
Okay, so that seems like a substantive difference between the two.
Oh, yeah.
States.
HSD does have DME analysts. Well, right, Ariel does not review like chronic DME codes, so.
For certain
But
things,
like-
yeah.
Certain things, but yes.
But like for
Yeah.
new CPT and ICD-10 codes or new, just regular old stuff, it's medical directors or staff behind closed doors.
Yep. Which is why we have this process now in Washington, when there's, you know, there have at times been very difficult, controversial decisions. And by creating an independent body with an independent evidence assessment and putting it in a public forum where anybody can participate. You take those decisions out of the agencies and you say, okay, well, let's use the evidence. Let's use it.
I mean, that makes total, and I'm sorry, I know I'm asking a bunch of questions, but they're all kind of the same question. So for the topics that are controversial, but where there's not evidence, so because there's not evidence, they wouldn't go to the HTA process. What happens to those? Those are decisions being made by staff, but if they're controversial, what?
Yeah, if there's truly no evidence, I don't think those are as challenging. Usually there's some evidence for the more controversial topics. And they'll go through a process like this, unless there's other factors. And then those are the kinds of topics we will take through this process. If
okay.
Controversy and a little bit of evidence, or that's what this process was designed for.
Okay.
But there might be important topics to people that are handled differently in corrections from Apple Health, from the state employees plan that don't come to your HTA, and those might be different policies. Those would be all made by the staff in those.
Correct.
So just like in Oregon, our state employees program might make a different decision than something Dawn makes in the Medicaid program, or if there were a HERC, she would. Or some of the durable medical business, they do. So it's only certain things rise to the level that they need this technology assessment. And I think one of the differences, you take how many topics on per year?
Yeah, we're able to do.
Sorry, 6?
Up to 6, maybe.
Yeah, and how many on a given PBS agenda, Ariel?
Every meeting.
25. Yeah.
Well, if you include all of the straightforward 50 to 100.
Straightforward, then it could be hundreds.
Last week was net.
Sorry.
And then my question kind of ties right in. It seems like if these conversations and if these decisions are on controversial topics, that means there are different groups that care deeply about that topic, special populations, people with disabilities. And I'm curious how you support those groups and also a broader conversation about equity. I know some of our conversations about equity have been really helpful in helping us see when perhaps something looks straightforward, but when you look at it from an equity lens, you realize, oh, wait, by putting this in place, we're actually creating a disparity here we hadn't thought of. And I've really appreciated that kind of elevated equity conversation in the last few years on the HERC, because I think it's really helped us avoid some unintended consequences too, especially when we're putting a requirement into place, say before someone gets this, they have to do this or something like that. So how do you handle equity in the special populations?
Well, so one of the aspects of the program is in the evidence report, and when the committee makes their decision, they're mandated to consider special populations. And so how, sometimes that's based always on the evidence. Sometimes it's just a conversation, like to your point about, okay, well, if we do implement this decision, who is going to be left out, or who are we overlooking if we make this decision? So yeah, different ways. Some of it, the majority of it is in evidence report to consider those special populations.
Yeah, equity has entered more into this committee deliberation in the past few years, and on some specific topics, I think it's been more of a factor in the conversation, and certainly has influenced the outcome when that's come into play. Access to certain laboratory tests or certain medical devices. So it's good to see and make sure that conversation is happening. And I think our panel is very much more sensitized to that now and is thinking more about those issues when they come up. We have discussed with our contractors, how are you seeing and how can we better incorporate these questions into our work, but we haven't made any formal changes to how we're asking for the evidence to be assessed at this point. And then, when the legislation was created, it did address, let's say, consider special populations. It names some of those considerations to factor in. On specific topics, if there is a recognizable special population, that will be added to the questions on that will first include any evidence that might be specific to a subgroup. I don't know if that helps answer your question.
Thank you.
Yeah.
That was actually my question was, yeah, so perfect segue. Because I see equity with an arrow in there. What I was just wondering if there was any kind of framework where, that's looked at, but it sounds. Thank you. So.
And I'll say, interesting, we've seen that word, equity can mean so many different things. So, equity's been presented in many different ways in the process.
Daphne had a question, then over to you, Kate.
Let's take Kate's question first. I can go ahead.
Okay, go ahead.
Yeah, just to stick on the equities, so one of the kind of terms that we've used kind of maybe more just past than recently, but still comes up for us a lot is the values and preferences of our population. So that gets into equity, gets into kind of cultural expectations. And I think we are in that space a lot, discussing those things, the equity aspects, the listening to public testimony, considering hearing our public comment. And I think that's a big part of what we're doing and considering. But it seems like your system, and please correct me because I'm probably not right here, is designed that maybe doesn't have as much of a spotlight. Or I don't know, correct that.
Well, and so that was, I can't remember what slide it was on, but it kind of talks about the three things that go into, that one too. But when it talks about like what the determination is based on, it's not just the evidence report, but it's also that public comment. It's also input from guidelines. It's not just that. It is to consider things like patient value and preferences, like, hey, that doesn't make sense for my lifestyle. But it seems like to get into this pipeline, like so many things that I think we get entrapped in and work on when we even get to this process, because they wouldn't have enough evidence. They wouldn't have enough high quality evidence for you guys to trigger this. So then the patients who are advocating for those sorts of treatments that really don't have sufficient evidence to use a great framework yet, those issues for you guys don't come up because they're filtered out in that pre-process. So how do you handle that?
Yep.
The public desire to have topics determined that don't have adequate.
Yeah, that's a great question. And this is not the process you want us to go through.
It's not, and I think we get stuck there sometimes, right?
So, yeah, we will receive petitions or get questions like, hey, can you review this? And have to explain, like, I don't think you know what you're asking for. And I don't think this is not the process. This is not the right process or investment for that review. And because the outcomes are covered with conditions, and it's supposed to be based on the evidence. So this is not, so it's really interesting to think about that spectrum of requester.
What's that filter like though? Like how does that get communicated, or what's the forum?
Yeah, so it's relatively rare that we receive a petition for something that's not maybe a perfect or good fit. I will say, and then it's been personal conversations at times or letters, or we basically have a decision tree about this program or internal review, and then prioritize those internal reviews, and then there'll be a separate internal review, as we talked about, from our internal policy team.
Then that requester would get a determination from the internal review process.
Correct. Yeah.
There's Daphne and Larry.
You covered a bit of what I wanted to talk about. I was interested to know how much emphasis there is on soliciting public comment. What does that process look like for you? How much is it considered? Is there a person who
does that or group people who does it for your process? Yeah, so in terms of soliciting public comment, we have it's a distribution list to anyone that's signed up who's interested in our program. And so when, the draft key questions are posted, when all these things happen along the way, those big bubbles that you saw there, then it gets sent out and so then people can submit their public comment. That public comment gets incorporated as being addressed essentially in the next iteration. So for the draft evidence report, the evidence vendors will reflect on that in their final evidence report. They'll have a public comment disposition where they get addressed. And two, in terms of, even topic selection, the associate medical director, the AMDG group that Josh mentioned, they'll discuss those, say, oh, okay, this was something that people really value, so we should prioritize that more. So there's definitely a lot of kind of interaction in that capacity, and even the public comment that happens at the meetings, the public meetings, that gets brought up by the clinical committee when they're discussing. So yes, lots of engagement. But did that answer your question, or were there more? What are your regular members who care is affected by health? Do you hear from those people? We definitely do. Advocates about those things. Yeah, we hear from a lot of manufacturers as well. But yeah. So do we.
Yeah, we don't hear from as many individuals who are impacted as we would like, I think, and we try to learn groups are attempting to do that, but that is usually the most meaningful. It often is some of the more powerful commentary is coming from people who have lived experience with something or with a bad insurance experience, where something's been denied. And we've had recent really, I think, rich comment from that. And then we have very active providers, depending on the subject. And so we can get very organized presentations, coordinated, which is often really helpful, I think, to the committee to understand the perspective of the community providers that might be impacted. But yeah, the most organized are the advocates, and then the occasional individual.
Yeah, and the hard part about when you get it from the individual who, like, it affects their insurance or their coverage, they'll contact us and they want to get the coverage changed. And we're like, well, this is kind of a long process with public comment. It can't just change really quickly. And so the hard part is getting people kind of involved earlier, like this might affect you 5 years down the road. So it's hard to get that engagement early on because you don't know what you're going to get, but that's the point of this is a rigorous process. Oh, okay.
Larry, Leslie, and then I'm going to ask a question that we haven't covered yet. But
2 questions. Is there a periodic state health assessment, and is that used as an input for what to evaluate?
Sorry.
Periodic state health assessment.
Like the purpose.
Like a Washington state of the state of health.
Do that.
It's public health.
Yeah, I can't say that we've used that as an input. Not to say it wouldn't be meaningful. I mean, certainly when we've looked at things related to diabetes, we've looked at the state rates and things like that to understand, the impact, remember the percentage. So no, answer no.
Second question. So my understanding is you're looking at medical coverage, necessity and coverage for the Medicaid program for teachers and for state employees. Is that correct?
And workers' compensation.
And workers' comp.
Those are the ones. See, so the original law mandated that the Uniform Medical Plan, which is the state's self-insured employees program, the Medicaid, and the workers' compensation program, those 3 programs were mandated to follow the outputs from this the Health Technology Clinical Committee. And then at the same time, the Department of Veterans Affairs was named and the Department of Corrections were named in the associated budget bills. So those 5 programs participated in organizing the program, and they were very active in many of probably the first decade of the program in informing what went through that process. And we know that corrections is still using our decisions. We haven't had great contact with Veterans Affairs in recent times. They're less impacted, I think, by this process. But yeah, those 3 programs were directed to do that.
So my question is, in terms of medical necessity and coverage, is it the same for all groups?
Not necessarily, though that is what we have strived to achieve. And the reason why it might be different is that term in there, which comes from the law, which says they shall follow it within their statutory framework. So each of those programs has a different governing law. Like Medicaid, for example, Medicaid can't necessarily follow HTCC decisions to a T because we have a single state agency and only the single state agency can make those decisions. So they have to interpret what the HTCC did and then make a decision. Is this right for our Medicaid population? And, workers' compensation has its own statutory framework. So not necessarily the same.
So that triggers my next question.
Yep.
Does that cause a difference in equity?
Yes, sure.
How do you reconcile
I don't know that it's a difference in equity because, it's a yes or no question. And I think it's not a yes or no answer, right? If you're an injured worker, you're in an injured worker system. Does that mean you should have the same coverage as if you were in the Medicaid system or in the Uniform Medical Plan system? I don't know. Is that an inequity or is that just a difference based on where you're ultimately where the payment is going to come from because of how you're insured? I don't know.
Is that something that you are looking at, or is that something you just?
Well, and so I can say that the way the state's trying to address that is through coordinated implementation. But that implementation is constrained by those different frameworks. So we have made great efforts to, for example, when implementing a decision on vitamin D, having everybody in the room agree from these different programs that, okay, when we implement this, we're going to implement it in this way. We're going to take the decision, which usually there's some interpretation that needs to happen, such that the programs agree, yeah, this is how the implementation will look. So, yeah, and we think I can't speak as a provider, but we would hope that if a person walked in and needed this treatment, and it wouldn't matter which of those programs they walked in from, that you would not have to think about, well, what's the policy difference, right? Because we know that's burdensome, right? So we hope
It's crazy making.
right, exactly. We're trying to reduce the crazy making.
That was the other big colored wedge.
Crazy making. 10, a little over 10 minutes left, so it's.
Thank you.
Yeah, so I think some of the most important work that I've seen the HERC do in some of the places, I think we've grown a lot in the years I've been here, is really around what to do in those circumstances when there isn't a lot of evidence. And I know that's not the space that you sit in, but I think the reason that it matters so much for what we have done is because typically it's kids or people with rare diseases that there's just not a lot of evidence, and it matters a lot in that person's life or in that population's life. So I don't know if you have the information now, but whatever it sounds like in Washington, those sorts of situations go to the internal review team. Do they have some sort of decision tree or something about how they grapple with covering something with, I wouldn't say no evidence, but it's often the things that have a little bit of evidence or inconclusive evidence, or, maybe kind of evidence that is really hard. Is there something that they've created to kind of create some consistency in their decisions there? Or are they just not covered?
I think it's probably different from not cover. I think for tenancy is at least so. My understanding of the different it depends, right? That's, you get an individual, if it's an individual case, you know, I think, the commercial plans have, you know, an IRO process in the end, if the plan says, you know, it's leaning towards not covering something, based on the evidence review, then there's an independent process that a person could go through for an appeal. For Medicaid, it's based on medical necessity, and in our state, we have some rules around how to use evidence to that medical necessity decision making, as to weigh the evidence and what there's a framework in one of our rules around how to make that decision on a case by case basis. I think it may be the same, similar to our workers' comp. And so I don't think there's a good answer to your question other than it ends up being a one-off decision based on that person's needs.
And a lot of my background is in guidelines. So in the guidelines world, there is a little bit more, you know, there's the evidence-based process, and then there's something called, some people use called the trustworthy consensus-based process, which I was involved with the World Federation of Hemophilia and their guidelines. And because that is a little bit more of a rare disease, just the process they went through to arrive at their decision, you know, involved not just evidence, because with some of those topics, there was a lot of evidence, but two, you know, clinical like experts in the field, but also incorporating all of those patients and patient values and preferences, because like one of the recommendations I think originally said, well, hemophilia shouldn't do this because it shouldn't be sports because it's dangerous. And then the people weighed in, they're like, that's crazy. We're going to do sports. Like, please change that. So they changed the recommendation based on it. So I think it's definitely, there's parallels in that.
I have a maybe a hard question to answer, but you know, now that you've been involved in this process for a while, and you may even be personally affected by it as a state employee, I'm not sure. How would you, you know, what parts of the process do you think are key that you would keep, and what things would you change if you had the power to legislate change it?
Well, what I wish for is, you know, I've seen how some other organizations employ health economists in their decision-making process, so they can see beforehand and see in maybe a future state model, you know, if we make this decision, what might it look like? And, you know, it can get very sophisticated, I think, but that's a resource I don't feel that we have sorted out yet how to apply. Yeah, but my personal interest, that's very much what it would be. We've had some very good reviews that have incorporated the cost effectiveness piece or the decision analytic piece, as far as like, you use this screening technology, you're going to get this yield. Then you see a table of like informing decision making, and then put that to a value, right? In a false positive. The whole thing, you can see the whole picture when you have more of that information. Those are really intensive reviews, I think, and I in an ideal world, I think we would pay health economists more in informing what we choose and informing how what the outcome looks like. Because I think our committee, I think you might feel this way, but I think our committee has told us this. You know, give us more utilization data, show us more about what this costs, because I think in a vacuum, if they see a little bit of evidence that this is effective in some cases, but there's no context on what's this doing, and they're not asked to consider the state budget, right? That's the other thing. They're doing this outside of like global thinking on the budget charge. So I think, anyway, it's a commission stuff, but it's bottom line, I think it would be great if we would know, if we make this decision, this is what we predict will happen to this system. That's the other thing, is we don't look at, okay, if you take this device away because it's not great evidence, any evidence that it does anything, but you know that's going to create a vacuum for other services. What does it look like when those services fill that void? And that's a question we get all the time, especially on that. that's not effective. That's just going to build something much worse than the state. That device that has no evidence.
And then, you know, there's that finite amount of money, right? So if you do end up covering everything, what does that mean? You know, that's when you're getting hospice care for 5 people that you can't cover. So, you know, there's always those considerations that should be taken into account that aren't always, right?
Yeah, that's great. Yeah.
I'm gonna maybe ask the last question, or if any other HERC members want to ask. Here's just one that I think crossed the minds of some people. Has your HPCC, basically your equivalent of HERC, has it ever lowered its coverage standards or their coverage decisions based on implementation factors? It's the service, you know, for patients who can access it in rural areas. Has it ever looked like, did they focus on getting the coverage policy right? Or do they regularly or seldomly say, we're gonna look at other factors about delivery of the health service to inform what the coverage policy will look like?
I think that's a good question. That goes back to the ethics question. I think when that comes in, it does play a role. I wouldn't say that it's something where there's absolutely no evidence of this, but we can cover it because it's the only alternative type thing. That's not the example I'm trying to offer, but you know, I do think it comes to that equity consideration. Like if that laboratory test is much more accessible than a traditional laboratory test or something, or a new laboratory test, then it makes access easier, even though maybe the evidence is perfect, but it's decent. I think that ends up as part of the conversation. Yeah, for sure.
Any parting questions, any parting thoughts? We have 5 minutes.
Regarding our HTCC, I thought, I had a question written down and then I saw a slide, it looked like the term limit was like 18 months for that role or be on that committee.
Oh, no. So our committee head can serve up to 9 years, and then they can serve until we find a replacement.
Figured this out and I was like, I should be kidding you.
18 months refers to the law says we have to consider pre-review every 18 months. But consider is, you know, so we're being much more purposeful about literature reviews the past, I'd say, 10 years. But when we publish our proposed topics, we ask for input and we often get input outside of that process. We'll take input at any point. If somebody thinks something is dated or there's new evidence, you know, we want to know that. We discuss that, put it on our list and hopefully review it. That's
You don't have to initiate the whole external process and there's just a new piece of evidence.
No, we would have to change something. Typically, we would have to go through the whole process. And the other 18 months, maybe that's the part that's confusing. You can't serve on the committee if in the past 18 months you've worked for a health technology assessment manufacturer, health technology manufacturer, or if you've worked for the state. So if you've been on one of our other state committees, you're technically contracted for that work. We need to have an 18-month gap.
Even the committee.
Another committee, yeah, if you're it's because the way it's worded, it's, you know, it's pretty tight language.
And is it voluntary? Is the HTCC a voluntary?
Well, we compensate committee members for their time at meetings. Yeah.
Wait, what?
Everybody see this right
Stay in from Castley.
You're licensed in Washington and would like to be on in Washington.
Yeah, all right.
Pretty experienced.
That's all the time we have.
Why do you, maybe you're in the, like, the consideration of what has Oregon done, what California done, what does Blue Cross say, what does Medicare say? When do you pull that in? That's something your city does? Or is that something that the external process incorporates in their presentation, and when does that
Yeah, so we have a couple of our medical directors here, but so the meeting process that we didn't get into detail on. So when we have a public meeting, the first thing we do is we introduce the day. So we'll do a short presentation explaining what the topics are, what the process is. For anybody, you'll see a presentation much like what you saw. We will then, any previous meeting business, so we'll finalize minutes from previous meetings or previous decisions. We'll go through the individual public comments. We will have prepped the chair for this in advance, and then we'll move to the new topic. And then the first thing on the new topic is the agency medical directors will present their take on why they recommended this topic, why it was selected, and what the current state of that, the coverage is for that topic, right? And then they'll offer their interpretation of evidence, and they'll also often point out what other payers are doing. So if your commission has made a decision on that, that might be cited by the medical directors in there. It would also have played a role in our topic selection. We scan a lot of other entities, but we're very much pay attention to what happens here in Oregon. So it influences our topic selection. It may influence how the information is presented from our medical directors on the state of that technology and what other payers are doing. And our vendors are also, they will do a summary of the payer landscape. I don't know if they're including, they probably in some cases have referred to work of other EPA, but their charge really, back to what a little detail is, our state law says for our committee makes a decision and there's a Medicare national coverage determination or decision, which is a very specific thing. And it's NCD, our committee has to either, if their decision differs from that, they have to explain why at the end of the decision process. Why is their decision, why does it differ from that? Or why does it differ from professional guidelines? So our vendors are charged with summarizing, is there a medical NCD, yes or no? Give the committee that information in the report, and the same for professional guidelines. So there'll be a summary of the guidelines in those reports. And so when the center does that work, there's a nice table in the report that we can cut and paste into the committee's decision aid. They have that information handy when they need it.
It's time for break for lunch. Thank you so much. What we're going to do here, first of all, apologies. Jessica has surveys. If you want to get to know your colleagues better, I think it's a good time to do that and just learn a little bit of non-business related stuff.
Get them into me at the end of lunch break, if you would, please.
Yeah, we'll see what we learn.
I'm going to put together a presentation. If we have time, we'll see it here. If not, I can email it to the group based on how interesting it is.
Well, so we're going to take a 15-minute break, and then we're going to divide up the table group staff. I'm going to, because this has to be a working lunch. So Daphne's going to give us directions about it.
Now or in the 8 minutes?
Why don't we do directions now, and then we can kind of.
So after you take your lunch and hang out for 15 minutes, we're going to break up into 4 groups. You may see blue, pink, red, or green thing on your table. If you're interested in talking about how we can better incorporate health equity into our decision processes, come to the blue table. If you're interested in how to understand the changing role of public comments in the HERC process, pink is your table. If you want to know how we apply evidence standards to your career, how has the view of your applying evidence changed over your HERC tenure? And that would come to green. And then this isn't, no, this is discussed, and there will be stuff. And then if you would like to do evidence discussions on some hypothetical conditions, you'll go over here on red. One of mine that I suggested didn't make the cut was count chocolates.
And as we do that out there.
So I'll put the descriptions on the tables, and then in the red section, you'll have a list of infectious diseases you can discuss. So self-select after you take your break for lunch, and we'll see you back at home.
Yeah, that's why we put the chairs on the inside, so they can make more cohesive discussion.
Are you gonna put up
Don't hear.
color to question? So
So I think we talked about a number of discussions. So one of the things we talked about is that we thought it might be helpful for HERC to have some guiding principle when we think about equity as it applies to the work we do. We recognize that there's a kind of broader definition for OHA. With many broad definitions, it can be hard to practically apply that to kind of the work that we have to do. So we started talking about what does equity kind of mean when we apply it to this. So one of the things we talked about is the concept of accessibility. Maybe that's one, and there's probably other guiding principles, but maybe there's a couple of 2-3 guiding principle kind of questions that we ask ourselves when we do our deliberations, and accessibility might be one of those things. And we talked through several examples where we have done that in the past, and there's examples of where we've at least implicitly thought about that, if not explicitly named it, in coming up with guidance out of hospital births, chest vest examples. We talked about the idea of incorporating data, which I know we're going to talk more about, but data to identify disparities as a starting point for which topics to take on. If there are groups that are already struggling with something, maybe that's something that we want to take up, as well as using data to identify unintended consequences of decisions. And what else am I missing anything?
Talk about race-based algorithms.
Yeah. Yeah. I don't know. We came up with a conclusion.
What's it based on originally?
That reminds me of the smoking.
Lots to say about there. More discussion. What about the group that had the hypothetical conditions? How did that exercise go?
I found it really helpful for different ways of presenting.
Can you speak up just because
So I was sitting in and listening, and we had several members in there who were looking at a mock-up that was created by staff from the center, and then a sort of a mock-up of the same data that I did. And I got really good feedback about how to better present kind of things. So if anyone else who's on any of our groups, if you run across something today, any materials, and you're like, this seems more clear, I can get it in my brain faster, this makes more sense to me in presentation of data, what pieces of data you want pulled out, context. One of the feedbacks was that some of the context that we put late in our summaries might be better early, before we start going through evidence. All of that is really good feedback, and I might experiment on how I'm presenting things and at the next few meetings, and I would love feedback. Like, this doesn't work, I hate this, or this made much more sense, it was more helpful, all that stuff.
Okay, we'll put packets with those 5 issues and then the more BBBS targeted summary versions. So if those of you who weren't in Red Group wish to look at them, they'll be over on that table.
This is a really valuable exercise because it felt like the conversations we have all the time. And I think it's almost like that would be a good thing to do intermittently as a not real topic for the BBBS. And I don't know about the evidence-based committee because I'm not on it, but and even maybe for HERC is to go through like a mock one, because you can learn a little bit about where our lanes are, what we're not talking about, why, we can think about, okay, when I presented it to you with the information about what other coverage guidelines exist in the beginning versus just telling you at the end, like, how did that influence you? Like, I don't know, you can see how different pieces of information, like one data review just talked about, like, the outcomes of the studies, and that was this study was downgraded due to the risk of bias. But then the other one talks about the other description of the evidence put together in a different format, says specifically that, the manufacturers of this sham surgery were actually all, funding the studies, and that all of the
surgeons in the studies were conflicted financially with, like, when you see that right at the beginning, you know, you take that RCT and then it just falls immediately in your consideration, whereas I think evidence was presented with all that, you really thought carefully about all these outcomes and all these trials. Whereas you can kind of like cut to the chase when you see the limitations of the research from the beginning. So just the order of events. So I just think that's a really useful exercise, maybe doing it as a HERC orientation or something.
Yeah.
Be fun for us.
Can I just pick up, you know, there's a concept which, you know, I do a lot of guideline and evidence development work, and I come to favor this idea of a best evidence approach, which, you know, one of the drawbacks of kind of systematic reviews is the important details get lost in this shuffle and this kind of black box. But invariably, there are specific studies that kind of drive the evidence base, and those become apparent. And, you know, one way to, if I'm understanding you correctly, is to take a best evidence approach when in discussing or presenting what we do. I mean, you know, there's the review, but you can also say, and I mean, you guys kind of do this anyways, but you know, here is the key study that is doing, and here's kind of some of the intricacies of it, because you're right, there are some hidden things there that are pretty difficult to, like you have to, you know what you're doing and look carefully to identify reporting bias and all this other stuff. And you can't do that across 10 different studies, but if you highlighted the ones that are likely to drive decision-making, you know, that's what we do.
Yeah, I like that.
All right, we have one more group, we're discussing over here. Oh, how is your view of evidence changed over your group?
Okay. So we were talking about how sort of earlier on, just that sort of the problems were perhaps a little more black and white. So it was a little bit easier, you know, because we were tackling the not quite so thorny ones. And as time has gone on, when there is perhaps less strong evidence for things, that the flip side of that is probably taking in more preferences and values of the patients, clinic members, consumers, whoever you want to call them. And we had a great discussion about continuous glucose monitors and which, you know, it's a challenge, and there's like great reasons why to cover them. Three problems.
Can I ask a question just kind of based on that continuous monitoring? Do we have time for that? Is that okay?
I want to make sure we get time for.
We're
out behind schedule, so.
Yeah, it was a perspective question.
Let's hold that for, we will have a substantial time here. So with that, Ariel, are you ready to, Jessica's got.
Your survey's done? I'll take that.
You guys have kept us too busy.
Give us 2 minutes.
Why don't you play me now and then maybe report at the 2 o'clock break?
Oh, wow, okay. I'm trying to get that done.
Okay, I speak Spanish, everyone.
It's other than English or Spanish.
All right, whenever you're ready. Ariel,
Military person.
¿De dónde viene tu español?
That side of the.
Go ahead, we have, need to make a place for our panelists.
And tell me something about yourself.
I lived in the United States. I lived in El Salvador.
Wow.
Peace Corps.
Yeah.
You use
Multnomah County.
But yes, no,
Yeah, so we're gonna.
I am a master gardener.
Neat.
Club.
Internal health information is at OHA, and they're gonna be giving us some presentation on what kind of what work they do and kind of how.
I also do
us. So we have Susan Otter and Piper Block. You want to introduce yourself? Do you want me to read your little bio? Very sign.
Introduce myself, I think that's fine. Hi, thanks for having us today. I'm Susan Otter. I use she, her pronouns. I'm the Director of Health Information Technology and Analytics Infrastructure for OHA. I co-direct our analytics teams with another director, Stacy Schubert. And we're excited to talk to you today about analytics and data resources that our analytics office has written. And we have Piper and then Chris Coombs online. Piper, do you want to introduce yourself?
Yeah. Hey, everyone. I'm Piper Block. I use she, her pronouns. I'm the research and data manager in the Office of Health Analytics. So Stacy Schubert is my direct supervisor, but also Susan. And I manage the health system meetings, so the all care, all claims team, the hospital financialization team, and then the healthcare workforce team. So if any of you, for those of you who are providers, if you have to take a survey with your license, when you your license renewed, I manage that program. You're welcome. And I'm going to be here to talk about mostly all care, all claims, but also hospital discharge.
Great. And then online we have Chris Kuhn. Do you want to introduce yourself?
Sure. Chris Kuhn. I'm the Medicaid Analytics and Data Integration Manager in Health Policy and Analytics. I report directly to Susan. My team supports the Medicaid program directly, more or less. The CCOs and the fee-for-service programs are the big part of our work. We will also work closely with some of the behavioral health stuff as needed. And part of my team also helps integrate some of our data sources for some of our online visual BI reporting that we have tried to integrate into our websites and stuff. So go back to Susan.
Great. Thanks, Chris. So we're going to walk through the data and analytics resources that we have available that might be of interest to her. And we'll have plenty of time for Q&A and discussion. Feel free to interrupt as we go if you have clarifying questions about what we're presenting as well. So let's go to the next slide. So we'll talk a little bit about how we're structured, our main data sources and reports, how to request analytic report, and then have some discussion. Next slide. So the mission of health analytics is to support OHA's strategic goal to eliminate health inequities by analyzing and presenting data about Oregon's health systems and by engaging partners to develop meaningful community-centered insights. Our scope is the kind of analytics function for OHA, for the Medicaid program, the behavioral health program, health insurance coverage, and reporting on the healthcare delivery system. Next slide. If you want to go to the next one. Oh, yes. So this is a slide just of the 10 analytics teams that we have between the Health Analytics Office that Stacy Schubert directs and the Office of Health IT and Analytics Infrastructure that I direct. And you can see our teams are organized by subject area. We have a quality metrics, surveys and reporting team, monitoring, evaluation, teams on behavioral health, et cetera. So if you're interested in more, we have more information about each of our teams on our website as well. And I think we'll keep going. Great. So this slide is a pretty high level overview of the main data sources that we use in our health analytics work across our teams. We've put a little asterisk on the data sources that may be especially relevant to HERC, and we'll go into each of those in more detail. But at a high level, there's kind of 4 types of data sources: healthcare administrative data, which we'll talk mostly about; hospital data, which besides the discharge data includes financial data and community benefit reporting. We have a number of surveys on health insurance, the workforce, consumer satisfaction, and mental health. And then we're increasingly leveraging data from other agencies, including the Oregon Department of Human Services, and Housing, Oregon Youth Authority, et cetera, especially as we're looking at reporting for our waiver, health-related social needs, and et cetera. So, next slide. And I just wanted to plug, we're trying to move more towards data dashboards, interactive self-service data dashboards. We have a web page that lists all of the data dashboards and links to them. We're going to talk about a few of these today. This is a screenshot of Medicaid enrollment report where you can look at who's enrolled in the Oregon Health Plan. And you can slice and dice the data by geography, age, eligibility groups, CCO, program. You can look at dual eligibles, et cetera, and by CCO, by open card or fee for service. We have a parallel dashboard that is around demographics that drills more in depth into our demographic categories. So, but anyway, there's other dashboards on that webpage. Yeah, go ahead.
I have a question about that. So when you're using the word Medicaid, you're talking just about the health benefit side of Medicaid, not long-term services and supports, right? So not people using developmental disability services or anything like that.
That's correct.
Just the health side.
Yeah,
okay.
That's right. Yeah, and as we're, getting more cross-agency connected and looking at other data sources, we're hearing more about the importance of having this kind of visibility into all of our Medicaid, programs. So thanks for.
And this is FFS and CCO?
That's correct. Yeah. Yep. So this is Oregon Health Plan, medical benefits, behavioral health benefits, dental benefits. Great. All right. I think I'm going to hand it to Chris Kuhn to dig more into our Medicaid administrative data.
Great. Thanks, Susan. We have a few slides here. I'll try to talk about what kind of data we have available in the MMIS, which is the system that we use to administer the Medicaid program in Oregon, at least from the sense of OHP. The MMIS is the Medicaid Management Information System. Every state has to have one, including territories. They're transactional in nature. Our system was designed specifically originally as a fee-for-service system, so it was there to process people's medical eligibility into the program as it exists in our state, which is enrolling them in CCOs, making sure they're eligible for the right funding streams and things like that. We have some data. Susan just showed you almost the perfect example of what the MMIS does is it has categories of eligibility that lets us show people and count people in different ways to show where they're doing, where they're at in the state and what might be going on with some of them. We can go to the next slide. The main two streams of information that we process through the MMIS is eligibility information, which is eligibility for the medical programs, and also claims or encounter data. When we say encounter data, we're basically claims data is what we would adjudicate ourselves for our fee-for-service program. Encounter data would have been adjudicated by the CCOs, and then the CCOs are under contracted requirements to submit those claims to us. But since they won't go through our financial system, we consider those only encounters because the CCO is who actually paid for those services. We can go to the next slide. This is roughly the flow of data for actual data use, how we would use the data ourselves to monitor the programs or just share the data with other people. The data originates in the MMIS system. It's getting information daily, hence the transactional nature that it is. So it'll get daily information for claims, also gets daily information from the eligibility systems that pass over the medically eligible people. There is basically a weekly financial cycle for the fee-for-service side where we process everything in a given week and then make payment to the providers at that point. That information then on a weekly basis is transferred down into our decision support and surveillance utilization review system, or what we would call DSERS. It's a data warehouse that basically allows us to work with the data without affecting the transactional system. So it's a snapshot every week of the most current data that was in the MMIS for us to work with. It goes all the way back to 2002 in this case because we migrated all the previous information from our previous MMIS into this system. The final system that we use regularly and was behind the information that you saw in that dashboard is what we call the Health Analytics Library. This data is downstream from DSERS. It's not really a database. It's more of a prepared data mart for feeding into our business intelligence reporting and or some other types of reporting that we do at the tail end for utilization management and monitoring. Go to the next slide. So here's a slide that just kind of explains a little bit of the differences between what's going on with our managed care organizations, the coordinated care entities, where we pay them a prospective payment for each member, and then they maintain the network for people, be it dental care, behavioral health, or physical health. They take care of that part of the enrolling people for providers and things like that. The fee for service, we also use Open Card as another name for that, is a more traditional healthcare model where we are directly paying the providers. So in our case, it's not necessarily from a top level down. It's more driven by what our members need and what providers will take these Medicaid members, and then we will work with them to get their bills in or claims, and we'll pay those directly. As there's a highlight down there that most of our Medicaid members are enrolled in a CCO. I think we're 92% of the Medicaid members are in a CCO right now. There are exemptions to going into a CCO. Medicare is one because we don't expect our CCOs to worry about that third-party payer type intervention if we know about it up front. The other big group is the tribal members in the state, is they can actually choose to opt in or out of CCO coverage as they feel more comfortable in what they want to get. We'll go to the next slide. This is a rough summary of what a claim and or encounter would look like. Encounters originated as what we would consider claims in a traditional sense. It's basically about who's receiving and who provided the service. It's where the service occurred, when the service occurred. It'll have the diagnosis codes associated with the visit, as well as any treatments or procedures that were given to that member. It can also be pharmacy claims that were dispensed. Those are separate. They come in through a claim, usually in a little bit of a separate sense because we have like point of sale type systems in the pharmacy world. So, but we get those. So we go to the next slide. Here's a little bit more detail about claims versus encounters. Claims are really the invoice that was submitted by the provider that explains all the services that they want and what they're expecting for reimbursement for those services that they rendered at that visit. Encounter claim was that kind of was the same thing for CCO. They made the payment, although they might not be doing direct payment. It may be a subcapitated arrangement depending on how many value-based agreements they have with their providers. But in theory, they should be passing the information through, almost mimicking a fee-for-service claim so that we can process it into our system. The paid amount that is represented on an encounter claim is probably not represented 100% of what the CCO paid to that provider because most of the time they're not doing direct payment models. They're doing some sort of other value-based payment that might have a performance or an incentive goal to it. So we can easily distinguish between the two in our data. So it's easy for us to know what claim came from a CCO and what were fee-for-service claims. We go to the next slide. And this is
I was going to pick it up from here, but
okay.
Yeah.
All right.
Thanks, Chris.
Thanks.
Any questions for Chris on sort of what's in MMIS or claims and encounters? Yeah, go ahead.
So the encounter data doesn't include, if I understand correctly, anything which would indicate the patient's actual health status. For instance, are they better? Are they worse? Are they the same? It doesn't include any lab data, for instance, a microalbumin level or an A1C. Is it possible to collect any of that data? And if it is it in computable form? Because that could really add to how patients are actually doing.
The data that we have is payment related data. So no, there's not any what would be the traditional EHR type data that's out there. Yes, the EHR data can be digitized and linked, but I don't know of too many systems out there that can integrate that data and use it in some sort of way that would be of value outside of an EHR. But that is a very good question to think about.
Yeah, and I would just add, some of our CCOs are more sophisticated and are able to bring in clinical data from electronic health records through technology, population management tools. We have a regional health information exchange in Oregon that works with some of our CCOs. They can look at that data for, interventions, identify where someone needs, further care coordination, that sort of thing. We don't collect that data at the OHA level. We do require for some CCO methods that data are collected from electronic health records to report on specific metrics. So in the past, we've had like an A1C, in control, not in control metric. Those data are currently reported at an aggregate level for that provider or clinic. And so it's not at the patient level, but that's where, we'd love to get to that down the road. There are some claims data that do point more directly to health outcomes, things like, did a screening occur, things like that. We have diagnoses, data, historical diagnoses. So there's a little bit that we can look at, but you're right, we don't have like clinical effectiveness data.
Thank you.
Yeah.
Is there any data on the denials?
Yeah, Chris, do you want to
generate
question about denials data?
For CCOs or fee for service or both?
Both.
When you say
you hear the
denial,
Like
yeah,
claims denial.
when you ask about denials, I mean, are you talking about denial of service or denial
Yeah.
of payment?
You would probably see denial of payment.
Yes. We can see denied service. I mean, that's a pretty rare thing in the Medicaid program in Oregon to actually have denied services, but we can kind of suss that out of our data if it's correctly billed to us. Denial of services would be more of a prior authorization type thing, and the CCOs handle that themselves. And we can see the fee for service prior authorization data if needed.
Thank you. I think you answered my question, which is
Sure.
kind of upstream. Where would we look for it?
Well,
And it sounds like,
I'd like to actually break that down a little bit. So there are several places where service can be denied. Provider can say, I'm not going to offer the service to my patient because the payer is not going to pay for it. OHA has no record of that. There probably is no record of that, except in the person's brain. Then you can have a prior authorization request, which can be denied. We have a record of that at a detailed level in the fee for service program. But for CCOs, we get very limited information because of the reporting requirements. If it's not a service subject to prior authorization, or if it's submitted without prior authorization, then there would be a denial of payment. So you're dealing with kind of an iceberg, and there's different kinds of levels of that. And furthermore, there can be claims denied for reasons like wrong provider ID, like just digits transposed, and telling whether, the same actual service can be represented by half a dozen or more attempts to get it paid for.
Right.
And it's a little hard to suss all that out. Go ahead, Josh.
Do you use that prior authorization denial data? It sounds like you have that fee for service.
It's fee for service is such a special population that it's not really representative. but we don't use it much.
You don't.
10%, yeah.
Or dictate to the CCOs what's on prior. Yeah. So it could be different. That's a huge.
Yeah, it is
Yes.
different.
Yes.
So the criteria can be, but are not required to be prior auth criteria. And then services HERC hasn't reviewed specifically or created guideline criteria. They can go get them from Interpol or make up their own, or whatever, as long as it's reasonable enough to pass the HERC process if it's challenged. Did I got that right, Don?
Yes. I would say though that CCOs are required to follow OHA guidelines, so when there are guideline notes, criteria, those are used.
Okay, so I've heard like sometimes it's not worth the cost to implement particular guideline, like we can't review the one I heard a number of years ago. We can't prior authorize every opioid prescription, like we don't have the staff.
Oh, that's true.
So there are cases like that. where
Yeah,
they're,
that
like,
makes sense.
They're not really implementable,
You need it.
but they could be
Okay.
implemented if a CCO chose to or felt it was in their interest.
So I want to piggyback on everyone's comment there. How, so sitting at this table with Health Evidence Review Commission and then seeing the two different avenues of being able to provide Medicaid through fee-for-service or CCO. Fee-for-service, that road's well paved, right? CCOs are paving their own road, so to speak. And I don't know exactly what's in their contracts, but it seems like there's less reporting for CCOs. And how does the OHA or HERC, for that matter, get a metric of services for the payment that they're receiving? Here, we're going to give you, here's your contract, we're going to give you X amount of dollars, and within your contract, you're responsible for these metrics. We're not getting you're not getting a report back on that.
That's a super important issue.
Anyway.
So this team will be able to speak to some of the metrics work that is done, but I will just offer to you and to anybody here, the CCO contract is a public document and you are totally welcome to Google it and review any part of it that you want and bring questions from it to any of us at OHA and it'll get routed to the right place. So that is the ways that OHA has worked and Susan's team is among those teams to do exactly what you're saying, try to get a handle on how are delivering service that has outcomes that we care about in exchange for the money that they're getting. That lives in some of these